So, what if I told you that the single most powerful diagnostic tool in all of medicine isn't some high-tech scanner, but a conversation? Today, we are diving deep into the art of taking a patient's history. And trust me, it's way more of a clinical investigation than it is a simple checklist.
Just look at this number for a second. 80%. That's the percentage of diagnoses that a really skilled clinician can make from the patient's story alone. We're talking before they even lay a hand on them for a physical exam, before any fancy tests are even ordered. It's absolutely fundamental.
And this quote just nails it, doesn't it? Getting good at this isn't just about being thorough. It's like having a diagnostic superpower. The exam and all the tests that come later, a lot of the time, they're just there to confirm what you already figured out from a really well-taken history. Now here's something that might surprise you. The whole diagnostic process, it actually starts before you ask a single question. It's all about setting the stage for a successful interview.
It all begins with these three super simple but critical steps. First, dressing the part. You know, that white coat and stethoscope? It's not just for show. It builds trust right away. Second, approaching from the patient's right side. It's an old convention, sure, but it's all about making that initial handshake and the later physical exam feel natural and easy. And maybe most important of all, you just observe. From the moment you walk in, is the patient struggling to breathe? Are they wincing in pain? The first clues are almost always visual.
Okay, so the stage is set. Now, the story can begin. Let's get into those crucial first few moments that build rapport and really set the tone for the entire consultation.
First things first, a clear introduction. Who you are, what your role is. No confusion. Then you ask for their permission to talk about their health. It's a simple question, but it shows a huge amount of respect. And only then do you start gathering that basic info, the biodata.
In this biodata, it is so much more than just paperwork. Every single piece is a potential clue. Seriously, think about it. If a 7-year-old comes in with rectal bleeding, your mind immediately goes to cancer. But a 10-year-old with the same symptom, you're thinking of something totally different, like a polyp. A coal miner with a cough makes you think of one thing. An office worker with a cough makes you think of another. See? Every little detail helps paint a much clearer diagnostic picture.
All right, now we're getting to the heart of it, the main story. And to give this whole process some structure, we're going to use a really powerful framework I call the 5 C's.
But before we do, we need to get one thing straight. We are not journalists here, okay? We're not just passively recording a story. We are clinicians taking a diagnostic history. A journalist reports what happened. A clinician is a detective, actively investigating why it's happening, hunting for the patterns and clues that point to a diagnosis.
It all boils down to this. Every single question you ask has to be a deliberate step towards solving the puzzle. This isn't just a friendly chat, it's a conversation with a very specific purpose. And here they are, the 5 C's that are going to guide our investigation. We've got characteristics, course, care, cause, and complications. Let's break down exactly what each of these means. Okay, the first C is characteristics. We need to understand the symptom inside and out. For something like pain, the SOCRATS mnemonic is an absolute lifesaver. You're asking about the site, the onset, the character. Is it sharp? Is it dull? Is it a burning feeling? You ask about radiation. Does that pain travel anywhere? You know, like how pain from a heart attack can shoot up into the jaw or down the left arm? It's this level of detail that turns a vague complaint into a huge diagnostic clue.
Next up, C number 2, course. This is all about the symptom's timeline, its journey. Is it slowly getting worse? Does it kind of come and go? Figuring out its trajectory over time is what helps you tell the difference between diseases that are acute, chronic, or maybe relapsing. The third C is care. Basically, what has the patient already done about this? Did they pop a painkiller that actually helped, or one that did nothing? Have they already been to see another doctor? This tells you what's already been tried and, just as importantly, how the illness has or hasn't responded to treatment.
All right, so now you can start to see how all these little pieces of information are building towards our 4th C, cause. This is where the real detective work kicks in a high gear. As you're listening to the patient's story, you are constantly building and refining a mental list of possible diagnoses. And that list, that's what we call your differential diagnosis.
So, you've got your list of suspects. How in the world do you find the real culprit? Well, you do it by asking very specific, targeted, close-ended questions that are designed to test your theories.
You're essentially looking for 2 things. We call them important positives and important negatives. An important positive is a symptom that supports your main suspect. But, and this is key, an important negative is the absence of a symptom that helps you cross another suspect off your list.
For example, with chest pain, asking about shortness of breath is looking for an important positive for a heart attack. But asking if the pain gets worse with a deep breath, that's looking for a clue that might rule out a heart attack and point you towards something else entirely, like an inflammation of the lung lining.
And that brings us to our final C, complications. You see, sometimes the reason a patient comes to see you isn't because of the primary disease itself, but because of a complication that's developed from it. A patient with long-term liver disease might show up because they're suddenly confused. That confusion is the complication. Spotting these is crucial for understanding just how serious the whole situation is.
So once you've mapped out that core story using our 5 C's, it's time to zoom out. Now we need to build a complete, 3-dimensional picture of the patient by adding in some really important layers of context.
This is where you ask about any past illnesses or surgeries, what medications they're on, any allergies. You'll ask about diseases that run in their family. We also need to explore their social life, things like smoking or alcohol use. And we finish with something called a review of systems. It's basically a quick head-to-toe screening for any other symptoms we might have missed, like headaches or joint pain, just to make sure no stone is left unturned.
So, we've got the structure, we have the framework. But it's so important to remember that this is much more than just a formula. It's a living, breathing skill.
It's really where the hard science of medicine meets the very human connection of listening. This is not a skill you just master and then you're done. It's a craft. It's something you hone and refine with every single patient you meet for your entire career.
And really, if you take one thing away from all this, let it be this. No scanner, no blood test, no fancy machine will ever replace the power of a clinician who is truly present in the room, actively listening, and connecting the dots in a patient's story. In the end, the most powerful medical instrument you will ever own is the one right between your ears. It's your brain, your empathy, your curiosity. So the only real question is, are you truly listening?